Hello everyone, Professor Beg here. This lecture is on sepsis, immunity gone rogue. We've been talking about inflammation, the lymphatic system, immunity, and we also talked about what happens when immunity fails. And sepsis is just a great example of when our immunity fails. And so we're going to kind of talk about, specifically how the body's normal protective response can spiral into sepsis, septic shock, and ultimately organ failure. We'll connect pathophysiology directly to what you'll see at the bedside, and so you can recognize these signs and symptoms early and act quickly. These are our learning objectives for this lesson. Please also complete the readings listed in your module, and you can use your study guide to take note and the key points provided in the module as well. So, the body's defense mechanism becomes the weapon. Basically, as you look at the slide, this is really the key idea I want you to remember. Sepsis is not just about infection. It's a dysregulated host response. That means that the immune system, which is supposed to protect us, actually becomes the source of the damage. So the bacteria themselves are not causing most of the harm. It's the body's overreaction. So basically, dysregulated host response. Here you can clearly see the difference between normal immunity and sepsis. Normally, the response is localized. You get targeted white blood cells, controlled vasodilation, and limited swelling. It's just your body's normal immune response to damage. But in sepsis, everything becomes systemic. Vasodilation is widespread instead of localized to the area of the damage. Fluid leaks everywhere, and blood pressure drops globally because now the fluid is leaking out of the vascular system everywhere into the body, causing the pressure to drop. SIRS is essentially the body's alarm system going off everywhere. It's a widespread inflammatory response that can be triggered by infection, but also by non-infectious causes like burns, trauma, pancreatitis. This is important because SIRS is the stage setter for sepsis and shock. As you can see, the infectious response that leads to sepsis is from bacteria, viruses, and fungi, and non-infectious is burns, crush injuries, severe pancreatitis, even myocardial infarction, a heart attack. This is the cascade. This basically shows the progression. We start with the initial insult, like the infection or trauma, then move into SIRS, the systemic inflammatory response. Remember the inflammatory response everywhere, all throughout the body. If the infection is driving it, we call it sepsis. From there, it progresses into septic shock and ultimately to MODS, multiple organ dysfunction, where multiple organs are failing. Think of it as a cascade, and our goal clinically is to interrupt it early before it gets to that point. This is one of the best visuals to kind of understand sepsis. In a normal vessel, as you can see on top, right, everything is tight and controlled. But in sepsis, as you can see down here, the vessels become dilated and leak. Fluid, proteins, and immune components leak out into the tissues instead of staying in the vascular system to help protect us. This leads to decreased blood pressure, poor circulation, which we also call, and what we call hypoperfusion. Remember, low perfusion in the body. Now, this slide shows what happens at the tissue level, right? Because of vasodilation and fluid leakage, oxygen can't effectively reach the cells. Remember, all our cells need oxygen. So the cells switch from aerobic to anaerobic metabolism. This is what leads to the increase in lactic acid, and that's like the standard that we use to check for sepsis when patients present with those symptoms, right? And so it built, the necrosis, the anaerobic metabolism basically leads to acid buildup. Now, the body tries to compensate, right? That's what our body does. But it actually makes things worse instead of better. Clotting increases, forming microthrombi that block the blood flow. At the same time, clotting factors get used up, leading to bleeding. So you end up with both clotting and bleeding. This is called DIC, disseminated intravascular coagulation. And it's a late and very serious complication. In the early septic shock, the body is still trying to compensate. Cardiac output is high, the skin is warm and flushed, and pulses are bounding because, remember, the body is trying to compensate and circulate. You'll also see tachypnea as the body tries to compensate for metabolic changes. It wants to get as much oxygen inside so the tissues don't have to switch to the anaerobic metabolism. This is often where we can still reverse things if we act quickly. And that's the reason why it's very important to recognize these signs early. For example, with cardiovascular, the high cardiac output, tachycardia, warm, flushed skin, bounding pulses, blowing, the lungs where you have your tachypnea. Late stage is the hypodynamic cold shock. Previously, we had the warm shock. Now it's the cold shock. As sepsis progresses, now the body's compensation is failing. Now cardiac output drops. Blood pressure fails. It goes low, really low, and the body starts shutting down peripheral circulation. And that's the reason why in patients that are going septic, we see the hypotension, severe hypotension, right? You'll see in the late stage, the hypodynamic, the cold shock stage, you'll see cool, clammy, mottled skin, decreased urine output. That's the reason why even as nurses, we really look for that urine output because now we know there's a renal shutdown. And you'll notice the altered mental status. This is a critical stage with a much higher risk of mortality. The earlier you detect it, the lower the mortality rate is from sepsis. Because remember, we don't want to reach to the MODS stage. So this table will help you differentiate early versus late shock. Early shock is hyperdynamic, high cardiac output, and low SVR, systemic vascular resistance, right? The skin appearance is warm, flushed, and pink. Mental status, anxious and restless. Urine output will be normal or slightly low. Then in the cold shock, cardiac output is failing. There's no compensation happening. Increased, systemic vascular resistance, where your vascular system is resisting and clamping down. The skin is cold, cool, mottled, and cyanotic, and mental status confused, lethargic, comatose sometimes. You basically have oliguria, very low urine output, or anuria, which is no urine output. Clinically, you watch for that shift because it signals deterioration. You see how immune activation leads to vascular changes, coagulation problems, and cardiac dysfunction. Then clinically, this shows up as cardiovascular instability, respiratory distress, right? When your body is trying to compensate, it's breathing in as much oxygen, you see the respiratory alkalosis, neurological changes, the changes in the mental status, and you'll see the renal dysfunction where you have low urine output leading to no urine output. One key takeaway that you can take from this is the mental status changes and increased respiratory rate. These are early warning signs. Because remember, respiratory status, the respirations are like one of the first signs that you're going to see. And the change in the respiratory rate is often the very early sign of sepsis. This over here is a cheat sheet on the pathophysiology of sepsis. Please kind of read over this. It's really important. You can print it out and use it as a cheat sheet. To diagnose septic shock, two key things must be present despite fluids, because fluids, the first thing that's given is fluids, right? Because remember, the blood pressure is low. You don't want the blood pressure dropping really low and perfusion to stop. First, persistent hypertension requires vasopressors to maintain the mean arterial pressure of at least 65. The body needs at least a map of 65 or higher to maintain oxygenation, perfusion and oxygenation. Second, an elevated lactate, greater than 2. Now, this tells us that perfusion is still inadequate at the cellular level, because when you see high lactic acid, that means that you have anaerobic metabolism happening at the cellular level, and that's not a good thing. That's rapid detection at bedside, right? This is your quick bedside screening tool. If the patient has 2 or more of these, low blood pressure, high respiratory rate, or altered mental status, you should think sepsis, right? So if you see a patient with GCS of less than 15, the Glasgow Coma Scale of less than 15, hypertension, systolic blood pressure under 100, tachypnea, respiratory rate greater than 22 breaths per minute. So if you see 2 of these, 2 or more of these, then think sepsis. When you're dealing with sepsis, time is very critical. The Sepsis 6 outlines what to do immediately, right? So you basically have 3 to take, 3 to give. The 3 you take are blood cultures, standard, gold standard, blood culture. We take those cultures before antibiotic administration. So we obtain blood cultures, measure lactate, serum lactate, and monitor strict urine output. So basically, we insert a catheter in the patient so we can monitor their urine output. So these are the 3 to take: blood cultures, lactate, urine output. The 3 things that are given are an oxygen, high flow oxygen, broad spectrum antibiotics, and fluid resuscitation. IV fluids are given to the patient. So this is to help maintain circulation, perfusion, and oxygenation. The diagnostics and screening. This slide basically summarizes everything. You're identifying sepsis using the Q-SOFA and labs like lactate, then immediately initiating treatment, fluids, antibiotics, vasopressors if needed, right? Early recognition and rapid action are what saves lives. So remember the 3 right here, 2 or more of these are the key labs, and this is the management of sepsis. Sepsis 6, take 3, give 3, and fluid resuscitation, the medications, and supportive care. So we basically want to stop it before it crashes, the system crashes. This is the key takeaway from this. Sepsis is like a ripple effect that can quickly turn into a crash. Your role as a nurse is to recognize those early symptoms. SIRS, systemic inflammatory response syndrome. Changes in vitals, respiratory rate, right? Big one. Altered mental status, GCS of less than 15. Intervene before the system fails. Here is an infographic of the sepsis continuum. It kind of puts everything together. So let's kind of walk through this real quick, right? And I want you guys to understand how to detect it early and how it's fixed, right? It all starts with the infection, bacteria, viruses, fungi, when they enter the body. Normally the lymphatic and immune systems, which we talked about as well, respond locally, trying to contain that infection. This is where inflammation is actually very helpful, because remember, inflammation is a immune response from your body, right? A defensive mechanism. It helps eliminate the threat and promotes healing. But if that response isn't controlled, it spreads systematically. This is what we call SIRS. At this point, the immune system becomes dysregulated. Remember, dysregulated host response. And that's when we move into sepsis. Now the response is no longer protective. Now it's on the opposite, and very opposite, it becomes harmful. So your body is basically harming itself. This leads to major physiologic changes: widespread vasodilation, capillary leak and microclot formation. Remember, the capillaries start leaking everywhere. Vasodilation happens, capillaries leak everywhere, and then you have your DIC, right? Your clotting is dysregulated. The result is decreased perfusion, reduced oxygen delivery to the tissues. If this continues, it progresses to septic shock and eventually MOTS, where multiple organs systems begin to fail. So a helpful way to think about this is like the fire alarm analogy. In a normal response, a small fire triggers a controlled reaction, but in sepsis, the alarm goes off everywhere. The sprinklers flood the building, and the damage just spreads beyond the original problem. So the key takeaway here is in sepsis, it's not just the infection causing the harm, it's the body's loss of immune regulation. And remember, time is tissue, right? The earlier we recognize this cascade, the better the outcome for our patients. So please review this, print those cheat sheets from the PowerPoint, and use them to help you fill out the study guides and read the keynotes and the assigned readings. That is it for our sepsis lecture.